All right, good afternoon, everyone, and thank you so very much for joining us for today's virtual educational program entitled Alzheimer's in Law Enforcement, Understanding Dementia Behaviors to Ensure Peaceful Interactions and Positive Outcomes. We are so excited about today's program, and we have a stellar lineup today, and we are thrilled to have so many local experts, veterans in the field joining us for today's conversation. Each one of our presenters, as well as our moderators, will tell you a little bit about themselves. Today's program is being recorded for educational purposes. There are a few housekeeping rules I want us to go over. We're asking that you will keep your microphone muted during the program because it will help with background noise. And also, if you would like to mute your camera, that will also help with bandwidth. So everyone, if you could do that, mute your microphone and your camera, everyone except our presenters. And during the Q&A portion of the program, you're more than welcome to go ahead and open up your camera because your presenters are going to be looking directly at you. If you have any questions, feel free to go ahead and enter those questions in the chat box down near the end of the screen. And we've got some amazing supportive staff members that are helping us to handle some of the chats. They'll be answering some of those questions in real time, and others questions are going to be posing back to our panel of experts. So today, this program is being supported by the Alzheimer's Association. The staff members that are available offering you tech support is Rachel Lawson, Lori Myers, and Jessica Samet. So we are thrilled to have this team of professionals here supporting you today. So before these experts tell you a little bit about themselves, I want to find out a little bit about you. So on your screen, you will see a poll. Please take a second and answer the poll for me. Perfect. So here are the results of the poll. Just a little bit of information to find out how you found out about this program. So it seems like most people found out about it from their job, their work. Awesome. And then there's one more poll. I'll launch that poll. Oh, lots of social workers on the call today. Caregivers, educators, awesome. Looks like the social workers are going to win out, Florinda. So we are thrilled that we have so many social workers joining us on the call today, and rightfully so. I'm also very happy to see so many law enforcement professionals on the call today as well, because I know dementia is a huge issue and concern for many folks. So now we're going to go ahead and turn it over to your moderators, and they're going to move the needle forward from here. I'll turn it over to Annette Clark.
Okay, thank you, Tina. I am so honored to be here with you today. I'm Annette Clark, Family Services Director with the Alzheimer's Association. I've been with the association for 16 amazing years doing this great work. And so my background is in gerontology, psychology, and sociology. And the reason that I'm so very passionate about this topic and actually asked to be one of the moderators today is that I'm not only passionate about those individuals living with Alzheimer's and their caregivers and making sure there's a positive interaction and experience with law enforcement, but I myself have been married to a police officer for 35 years. And I want to make sure that he and his coworkers also have a very positive experience, especially when they're out in the field dealing with individuals who may be experiencing behaviors or communication issues. I want to make sure that at the end of the day, everyone gets home safe. So if we meet that goal today by having this discussion, I'm happy. Florinda, how about you?
Hello, everyone. My name is Florinda Blocker, and I am a recent graduate of the Masters of Social Work program I've been an intern with the Alzheimer's Association since January, and I'm just excited to be on this platform to just, with everything going on, I'm just really interested in law enforcement and social work. So thank you for having me.
Okay, we will open it up for our panelists to just give us a kind of a little scenario about what you do and how come you're with us today. Let's start with Sergeant Sutton.
I am Tim Sutton. I'm a police officer here in the metro area of Richmond. I am a first line supervisor, sergeant, patrol sergeant. Pretty much grew up in Virginia, went to James Madison University, graduated with a business degree. Started to work on a master's, got tired of school, so a friend of mine suggested law enforcement. I ended up 89 starting with a law enforcement agency, and after 4 years, I ended up switching departments. In 2003, I started running a program for my agency that deals with wandering. It's a tracking system and deal with anybody with cognitive issues. So I was going out and meeting a lot of families dealing with cognitive issues, many of whom had Alzheimer's or another form of dementia. And I began to realize that we were responding, law enforcement was responding on a lot of calls for service, not just the wandering where the caregiver turned around and the individual was gone, but a lot of calls for service we were responding on were directly related to the dementia. And, you know, I made a commitment to educate myself and get out there, public safety, and I train other audiences, but to train people on understanding dementia and the behaviors related so that we can have these peaceful outcomes. And like you said, I'm going home at the end of the night, but what we're striving for is everybody going home safe at the end of the night.
Well, thank you for your service. We greatly appreciate that. How about you, Dr. Young? What
Hello,
brings
everyone.
you today?
Hello, everyone. So my name is Dr. Ericka Young. I have a medical degree from New York College of Osteopathic Medicine. In 2016, 2015, 16, I decided to go back to school to get my Master's of Public Health, and I did an internship through the Alzheimer's Association. And ever since then, I have been very much involved with the association, and I'm very proud of that involvement. Currently, I am the clinical director at the Petersburg Federal Correctional Center here in Petersburg, Virginia, where I am over the clinic for approximately 7 medical providers at this point, but we are responsible for approximately 27 to 3,000 inmates, federal inmates. Since I got here, the one thing that I have noticed is there's a definite increase in the dementia population here within the facility as well as other facilities. And I also found that the correctional officers really were not trained on how to handle someone who was having any sort of sundowning or having issues with their dementia. And so I've taken upon myself to try to educate officers as well as providers regarding dementia, along with a lot of other issues that we see in the federal prison system.
Wow. Well, thank you for your service. Thank you for your commitment to the cause, and we're glad to have you. How about
Thank
you,
you.
Major Dabney? We'll come back to you, Major Dabney. Maybe there may be an issue. I know that you're joining us via phone today, so we'll come back to you. How about you, Dr. Aravich?
I thank you for having me. Thank you to Tina Thomas in particular. I guess if you wanted to ask who I am, like Winnie the Pooh, I'm a bear of little brain, and big words hurt me. I've been accused of being a neuroscientist, having the brain of a neuroscientist and the heart of a social worker. So I fight very passionately for persons with disabilities in general, together with those who have dementia in particular. So I'm on a whole bunch of different state organizations. I regularly present on Capitol Hill about the epidemic of fatal behavioral and neurological disorders, including dementia. I'm a professor at Eastern Virginia Medical School, and among other things in our geriatrics program there. So that's a little bit about who I am. Oh, I come from the coalfields in Pennsylvania. I'd be remiss if I didn't call it Appalachia with a capital A, because that's what we call it north of the Mason-Dixon line. But let me just say it's the same coalfields as in Appalachia, and I'm very, very proud to come from nowhere and wish in many ways to reach those of you who are out in rural America where my heart really is. So that's pretty much who I am. Thanks.
Oh, thank you. Thank you. And for someone who lives in rural America, I appreciate that. So thank you. Thank you for being here with us. Major Dabney, are you available now? Can you hear us? And
Yes, can you hear me?
I can. Would you like to tell us a little bit about yourself?
Yes, I've been with Richmond City Sheriff's Office for 21 years. Currently, my team and I, we manage the Sheriff's external programs. We have a senior program called Are You OK? And we also have Project Lifesaver. Currently, we have an estimated 80 families or so we service every day. And let's see, I attended J. Sargent Reynolds Community College and Virginia Union University with a major in criminal justice. And just happy to be on the call and to contribute.
Good. Well, thank you for your service and thank you for your dedication to making the lives of individuals living with dementia better. So thank you all. So I am watching the numbers tick up, and so I think I would be remiss if I didn't remind everyone about the importance of dropping your questions, your comments, anything that you need to tell us in the chat box, and Lori and Jessica will monitor those, and we'll be happy to ask any of the questions that you may have. Or we know that in addition to the wealth of knowledge on the panel, that we also have a wealth of knowledge in attendees. So if you know of a resource that might be helpful to the collective group, please make sure to drop that in the box. We will try to share all the resources that are mentioned today to the best of our ability. So as the moderator, without further ado, what I'm going to do is I am going to read a scenario to you to get us jump started into the program today. And unfortunately, it's a real life event. Now, we have changed the names of the individuals and we've changed the location, but the gist of it is true. And what I'll do is I'll read that and then we will start out with some questions. We will have a Q&A time, and then we're going to wrap up everything by talking about some resources for you to put in your toolkit, and we're going to also highlight some things that you might want to know about the association program-wise and about events that we have upcoming and walks. So this is my scenario that will help us start this conversation. When police arrived at the Tiffany House Living Complex for seniors in Fort Lauderdale, Florida, they found 90-year-old Bess Kleinman on the floor, slumped against her bed with a plastic trash bag over her face. She had been suffocated. Detectives did not have to look far for Kleinman's killer. Her next-door neighbor, Felix Freed, who was 72 years old, had told the night security guard that he had killed Miss Bess, according to the police. The slaying shocked the residents and staff, of course. Freed and Kleinman had become very close friends. They would often walk together and share meals. He would read to her whenever she'd like, and he would often unlock the door for her when her hands were trembling too much. He could not explain or offer a reason why he had killed her. Freed was charged with first-degree murder, even though all involved, the nursing home staff, the police, the prosecutor, his family, everyone all agreed that he had dementia. Freed would eventually spend nearly in the Broward County Jail and almost 2 years in Florida State Hospital for the criminally insane in Chattahoochee, Florida, before the charge was eventually dropped. Finally, he was released to another assisted living facility that could ensure not only his safety, but the safety of others around him. The nearly 3 years in the criminal justice system were very, very difficult for him. George Rears, a public defender who represented Freed, shared, "He was scared to death all of the time, and he appeared to deteriorate more quickly than he would have. He would cry. He was often very confused. He would walk in circles in his room. It was a tragic, sad situation." Freed's case is a dramatic illustration of a wrenching problem that is becoming more common as the number of older adults and those living with dementia is on the rise. People with Alzheimer's disease and other forms of mental deterioration are increasingly getting entangled with law enforcement. Thus is why we're opening this conversation today. That has police, prosecutors, judges, psychiatric workers, and caregivers struggling to balance the humane treatment of a vulnerable but sometimes volatile segment of the population against the needs to protect the public at large. So we're going to start out with just a couple questions for Dr. Young, since that kind of seems to be in your lane. Can a person with dementia today be charged with a crime?
Well, yes, they can. This actually happens more often than people really think. What we see is people will be charged with a crime, and while the prosecutors and judges are trying to sort through all of that, they are detained in a facility. While they're detained in a facility, people like myself are tasked to care for them. One of the things we also see is we also see people who have never been to a doctor. They have really never had a diagnosis of dementia. Then they see a physician such as myself, and the first thing we see is, oh, this individual has dementia. In the criminal justice system, it is very, very difficult to manage these types of individuals. Within the federal system, for the entire United States, we have 122 institutions. We currently have one dementia unit, and it holds 20 individuals, and that's it. The waiting list is about 1.5 years to 2 years long. Once these individuals are identified, we try our hardest to transfer them to better facilities that can better manage them. However, it is quite difficult for many reasons. One of the reasons, we don't have the resources within the system to properly care for these individuals. We also find that these individuals will develop dementia while in custody, which brings up yet another issue. They eventually will need to be transferred, and a lot of the correctional officers, they don't know that this person has dementia. We typically figure it out when a cellmate or someone moves who has been their caregiver, and then we start seeing sundowning, we start seeing wandering, that sort of thing. Once an individual is in the criminal justice system, it is very difficult to get that person removed from the system. So in this case that you presented, yes, this person definitely was charged with a crime, but it took 3 years for everyone to kind of sort through all of the facts. During that 3 years, you will definitely see a decline because this individual was probably moved from institution to institution. This individual was probably confused a lot because people who are generally in corrections, they don't understand that when you remove an individual from their normal surroundings, that they will, in fact, become very confused. Sometimes they can lash out. Sometimes you can see anxieties, a multitude of different symptoms that you will see.
Right. Thank you so much. I think most individuals do not realize just how prevalent that is. And for individuals who are incarcerated for multiple years and age in place in the prison system, I'm sure this is very, very prevalent. Are there organizations or groups that are outside of the community that are providing support to you, I hope? Or is that just not something that's available?
At this time, it's not available. What people generally also don't realize, and this also includes our judges and prosecutors, the prison system is about 20 to 22 years behind the times. So to get someone or an outside organization to participate in the prison system, it almost takes an act of Congress. So you have to have that, every individual has to have a background check before they could enter into the facility. And then they have to, of course, be sponsored by a certain individual. It's a lot of paperwork, of which it takes months to get that approved. At this time, no one is able to, from the outside environment, really provide us with those services. So we're left with the people who are employed there, learning about what we need to teach people, and then turning around and educating other officers. For example, we have a refresher course that is taught annually and that is mandatory for all staff members. Currently, we're trying to get dementia training for the correctional officers incorporated into that program. Currently, that program, it mentions dementia, and we have about 2 to 4 sentences that's mentioned. So there's a lot more that needs to be done.
Mm-hmm. Mm-hmm. I have heard that many people learn of their dementia diagnosis once they are actually incarcerated. Maybe they're arrested for some particular crime and then they are incarcerated, and you all as physicians there make that diagnosis.
That's correct.
Is that,
that's correct.
Oh, okay. All right.
So a lot of the times people, unfortunately, are, they do not have access to health care on the outside. When we see them, we're required to perform what they call a 14-day physical. So within 14 to 30 days of their arrival, we perform a physical exam on them. And part of that physical exam is doing not only the physical portion, but also assessing their mental health. Quite often, I would say about 20% of the time, I have come across inmates who I've done a mini mental status exam, and they have completely failed the exam. I've had numbers as low as 13, 14 out of 30. And these are individuals that have been in the system for quite some time. So not only do you have that particular problem to combat, you also have practitioners who are not aware as well. They're not always aware of some of the signs and the symptoms of an individual who is either just entering or has been in the criminal justice system for some time for progressive disease or dementia. For example, we did have an individual who was brand new to the system. This individual was in his 70s and had been evaluated by 3 other physicians before he got to me. And none of them picked up on the fact that when he would sit, he would stare off into space. And it would take him a minute to sort of come back to you, and he couldn't remember anything you just spoke about. When I investigated that a little further and performed a mini mental status exam, his number was 20 out of 30. And so it was pretty evident that this individual had dementia, but other practitioners had not picked up on that.
Okay. All right. Thank you for telling us about that. Before we move to a couple questions that Florinda has to pose, why don't we get others' interactions about the scenario that I presented? Do you think that's a fairly common scenario? Does it happen more than we want to admit?
I would say it does. The officer, the street officer, or the investigator who ends up responding to these calls, we're there to establish probable cause. Is there probable cause to make the arrest? Many times there is probable cause. We're not saying we don't convict them, find them guilty on the street. Our job is to take them to a magistrate, swear to the facts of the case, and the magistrate is who ends up issuing that warrant where they're placed into a correction facility. The centerpiece to all of this, while people do develop dementia while they are in correction facilities, they may go in without it, may develop it during their stay, but sometimes they have got it. And what needs to happen is your prosecutors, your Commonwealth attorneys, your judges, they need training to understand and pick up on some of the signs so that they can make an educated decision on whether or not this individual needs to be incarcerated, or if there are other services that they can order to be put in place for this person. So, I'm up for training anybody and everybody, even the general public. I think everybody needs to understand it. But, we've got first line officers out there who may get trained, maybe put in a position where they do have to place somebody under arrest who has dementia. But it's that middle piece right there, I think, that could weed through a lot of it and keep that from happening where people are being placed in the correction facilities. Our job is to try to do what we can to take care of the situation, make the situation better. Sometimes that entails arrest, sometimes it entails incarceration, but there are many times when there could be an alternative means of dealing with the situation to prevent Dr. Young from having to constantly see people.
This is Paul Aravich. I'll just comment that this case reveals the epidemic we face of not only dementia in general, but the lack of a system of care that takes care of people after the diagnosis and before the diagnosis. It's really horrifying to hear, at least for me, Dr. Young state that the individual that had no health insurance or no access to care before they went into the correctional facility. I think we can agree to disagree on how to get health care and how to get health insurance and access to persons. But when I'm on Capitol Hill, I tell the members, is it true the last 5 words of the Pledge of Allegiance are liberty and justice for some, or liberty and justice for all? We clearly need to do better community-based stuff so that the person doesn't kill someone or injure himself. And I've been very honored to work with the Virginia Coalition for Elder Abuse on a number of different programs. One of the very first programs was the warden then of the Deerfield Correctional Facility in Franklin, Virginia, one of the first geriatric correctional facilities in the world. They have a dedicated Alzheimer's unit. He told us at the conference that the persons within his facility were getting better care than his mother would get outside in the community. That speaks volumes about where we need to go by way of healthcare reform and access to care by everyone.
Absolutely, absolutely. Dr. Aravich, you hold that thought because we're coming to you. Dr. Young, thank you so much for bringing that perspective to the conversation. That was so insightful, as many people don't know about the criminal justice system and how dementia citizens are affected when a crime is committed. So this is a great opportunity to bring Dr. Aravich in, just like he was saying. He was talking about inequalities between and within communities, not only in the justice system, but in medical care. So there is data to suggest that there are continued challenges at all stages of the dementia journey, from prevention, through diagnosis, care, and end of life. It's known that older or just African Americans are at higher risk for Alzheimer's disease and other causes of dementia. And some research suggests that even racism is one of the factors behind that increased risk. Dr. Aravich, could daily and lifetime discriminations be the cause of increased dementia in Black people?
Well, it's a really important question that you're asking about health disparities. The number 2 overarching goal of Healthy People 2030 is the elimination of health disparities, such as the one you're just mentioning with the dementias. And so the question becomes, are they biological or are they determined by the social determinants of health? There is no biological basis for the concept of race. Differences across ethnicity and race are not going to be due to genetic issues. They're going to be due to different social determinants of health. In some racial ethnic groups, the poverty rate is double than what it is in other groups. And poverty alone is one of the single easiest ways to make people sick from any number of different things. And so the whole issue of how we can address those disparities is a really important one. And I would call attention to the last month's Lancet Dementia Commission report, Lancet Dementia Commission report, about 12 modifiable risk factors that they believe would prevent around 40% of all dementia. And a whole bunch of them are social determinants of health. Some of them are existing cardiovascular factors, which vary from race and ethnicity, like hypertension, diabetes, obesity, those kinds of things. Others relate to education level, social isolation. There's some really interesting data now that they feel there's a consensus that traumatic brain injury is a major risk factor for that. And lots of persons in the criminal justice system suffer traumatic brain injuries either before or when they're in the criminal justice system. Even air pollution has now been linked to an increased risk of dementia. Where I live here in Hampton Roads, there's some very significant coal depots, and the neighborhoods that surround those coal depots are poor neighborhoods. So there's lots more air pollution there. Is that because is a biological difference, or is that because it's a social determinant of health issue? It's pretty sad that we have to deal with persons who have behavioral complications in our criminal justice system, because that's the most expensive, least effective place to deal with these issues. If we could only improve our community-based training, not just simply for law enforcement, judges, the whole criminal justice system, but for all persons, I think we'd be way better off than we currently are. So very, very much thank you for asking that question.
Yes, absolutely. So what I hear you saying is that those social determinants and additional medical issues, diabetes, educational level, all of those are really risk factors that increase African Americans, risk for having dementia. And so, Dr. Aravich, why does dementia cause bad behaviors? What's happening to the person's dementia's brain that's causing this?
Well, let me just say, science does not answer the why question, kind of answers the how question. Why things happen is existential, philosophical, spiritual. We could just say that it is a pathology associated with many of the dementias. Now, we need to clarify what we mean by dementia, first of all, and those that are reversible and those that are not, as we start to talk about the challenging behavior issue. The primary reversible cause of dementia is polypharmacy. The nephrologist doesn't know what the cardiologist is doing, who doesn't know what the pulmonologist is doing. So before you know it, you got somebody on 20 different medications adversely interacting. You can like the Affordable Care Act or not like the Affordable Care Act, but the annual Medicare wellness visit is one opportunity for clinicians to sort through all of that polypharmacy. And my colleagues at the geriatrics program here at EVMS spend a lot of time doing that, taking people off contraindicated medications. Another reversible cause is things related to malnutrition and hydrational status. Correct me if I'm wrong, but when you're tired and hungry, haven't been sleeping, you're a little bit on the cranky side, just everything else being equal. Now, the irreversible forms of dementia, the number one, most prevalent one would be Alzheimer's dementia, but there's probably 20 others that we could talk about. I won't, but the top four would be Alzheimer's vascular, Lewy body dementia, and frontal temporal dementia. They're all different, but how are they called dementia? Well, mistake number one that a lot of people make with dementia is you must have a memory loss. That's not true. Alzheimer's for that definition, you do need a memory loss. But for example, for vascular dementia or frontal temporal dementia, a memory loss is not required. There are 5 cognitive domains that are typically screened. You got to have, for the diagnosis of dementia, 2 of the 5, and then for the diagnosis of Alzheimer's disease, 3 of the 5. This is in persons who are already having impairments in their social and physical functioning in life and are showing a progressive decline from baseline. But the 5 cognitive measures would be language issues, word searching, that kind of stuff. A second one would be recent memory loss. A third one would be judgment and executive planning. So you put the iron in the refrigerator, for example. Another one is visual spatial stuff, a real problem when it comes to driving and accidents with persons who have impaired cognition. And then the last one is changes in personality that are occurring, that are not due to ongoing depression and so on. So you got to have a loss of 2 of those domains. So understand, you don't have to have a loss in memory to be diagnosed with one or another types of dementia. You do need that for the diagnosis of Alzheimer's disease. Now, I'm going to show you an Alzheimer's brain because I bring brains all over the place, including to Capitol Hill. And what do the security people tell me every time I go to Capitol Hill? Thank God we finally have some brains up here. All right. So this person, not sure how I do this. Oh, here we go. This person was an older woman who died from Alzheimer's. So I don't know if you guys know this, not all patients are white middle-class men. There's like a whole bunch of people that don't fit that description. And when it comes to Alzheimer's disease, it's very much a women's health issue. Alzheimer's disease affects women to a greater extent than men. So this is indeed coming from a woman who died from it. It's not a correlation. It is a cause of death. Cause of death for this person is going to be Alzheimer's disease. The proximate cause would be aspiration pneumonia or any number of other kinds of things. Now, when we talk about vascular dementia, little strokes and stuff like that, men, men, men. You talk about a dementia called Lewy body dementia, men, men, men. So it really varies as to which type of dementia you're looking at. The one that I wish no one would have would be frontal temporal dementia. That's the part of the brain, the frontal, prefrontal stuff that puts the brakes on impulsive behavior and so on. Regardless of whether there's any memory loss, these are the people who are really impulsive and the ones that are going to strike out with challenging behaviors. And if the poor caregiver who's burnt out, and most are women, burnt out herself and doesn't have resources around her, and she's threatened by the loved one who has frontotemporal dementia, in the course of defending herself, she may strike out and injure that individual. And now we have an elder abuse kind of thing going on. This is why law enforcement and everybody else has to consider the triad. You look at the perpetrator and the circumstances around that person. You look at the victim and the circumstances around that person, but you also need to look at the environment. Are they alone together, isolated, no money, no resources, no help from other places? It's really sad to think of that burnt out caregiver injuring the loved one as she tries to protect herself without the resources that she deserves. Now, I told NASA in one of the very first ever TEDx talks, rocket science is for wimps, the real action is neuroscience. How come we cannot figure out a better way to deal with these different dementias, aside from arresting persons who commit crimes and incarcerating them? There must certainly be a better way. And so law enforcement, you gotta consider not just the victim, not just the perpetrator, but you must also consider the environment around which the person and all the events are happening. I could go on, I'll stop there.
Yes, well, thank you.
I'd like to just piggyback off of what Dr. Aravich said. All of those risk factors are prevalent within the correctional system. We have a large amount of African Americans. We have a large amount of diabetes, coronary artery disease, and usually when we see them, they're severe.
So, Dr. Young, are you saying among the issues of criminal justice reform that we should be talking more about is what to do with persons incarcerated with dementia? Is that what I heard you say?
Absolutely. Part of the problem that I see, poor control of some of the risk factors that you just named. For example, I have a population of about 500 out of the 2,500 individuals here, all men, who have diabetes. Of those 500, I can honestly say maybe 100 of them are currently controlled. Their diabetes is usually all over the place. The A1Cs are horrible, but there are other factors as to why. In the commissary, they only have junk food mainly. We have a lot of individuals who don't drink water for multiple reasons. And exercise. If we have an individual who's in special housing for an extended period of time, there's no exercise. There's very limited water. They are only going to be able to consume the food that they're given, which is usually high in carbs. So it's very difficult to manage these issues within the criminal justice system. That being said, it seems that everybody they're very surprised to hear, oh my goodness, we have an increase in dementia. Well, of course we do.
But could I add the point that maybe a lot of people don't recognize? The prisons and jails are long-term care facilities. Obviously, our jails are not supposed to be that long, but sometimes are very long. And so it's a different perspective. And I'm on the governor's long-term care task force for COVID-19. I'm pleased to see the Department of Health has been reporting out the statistics that have occurred within our jail system, not within the federal system, and certainly not within the VA system. Those are silos. It's impossible to get numbers from the state to be parallel with those that are in the federal kinds of things. I've been arguing we need to get more numbers from what's happening in these other facilities besides our jails. But the fact of the matter is, one of the risk factors for dementia is social isolation. And pretty much that's one of the pieces of, that's the deal when it comes to being incarcerated. And so I'm going to show you a part of the brain right here, deep inside the skull, has some pins. You can't see the detail there, but the pins are in different parts of something called the hippocampal formation. And there is part of that brain physically injured by social deprivation in non-human primates. Psychosocial deprivation physically injures the brain. How many people in our correctional facilities suffer from that? How many caregivers are suffering from that? How many people thrown away in nursing facilities are suffering from that? We have, for example, Professor Dunstan from VUMS is on this call here with a program our students organized called Beyond Clinic Walls. They're reaching out in partnership with a number of organizations in Southampton Roads to just say hello to people who are older and alone and isolated. We tend to not appreciate the significance of psychosocial deprivation. It's a major public health problem.
Thank you so much for that. And I can feel your passion. I can feel it. And we are going to talk a little bit more about that for sure in just a bit. And thank you so much for giving us maybe those signs of dementia and talking about the different types of dementia that may cause maybe increased likelihood for behaviors. And so I want to circle back and take us into Sergeant Sutton's world and talk a little bit about how law enforcement officers are currently out in the field dealing with individuals with dementia. What sort of calls are you seeing? What sort of interactions are you having? And then I want to ask you specifically about, maybe driving and some of the others, but give us a scenario about a typical call.
Well, I will piggyback also off of Dr. Aravich. He said liberty and justice for all. When I was sworn in as a law enforcement officer, I was sworn in to serve and protect any population. So you can apply that to anything going on these days. I was sworn to an oath of office to serve and protect all populations, not any in particular. But we are law enforcement. I know over the years, as I've educated myself, learned more about it, and listened to the radio while I'm working, we're dealing with numerous calls every week that are directly related to a form of dementia. I mean, as of last week, we had a gentleman call in saying his vehicle's been stolen. Well, his wife, his second wife, who he's married to now, had hid the vehicle in the apartment complex because she knew he was going to try to leave. We got there, he's telling us that he needs to get to Texas where his wife is, which happens to be his ex-wife. He still thinks he's married to her and somebody has stolen the car. So my officers, you have to be very strategic, very creative in interacting, because no law has been broken. So to be able to get in there and train officers to understand why he thinks his car is stolen, why he thinks he's still married to this his ex-wife, it's a very delicate situation to deal with, and there is no simple solution to the problem. We will probably be back out there to deal with the same thing again. But we're trying to teach the officers, the Alzheimer's Association, the different resources that are out there to pass on to the caregiver, to pass on to the wife or whoever's taking, care partner, taking care of them. But we are, whether it's shoplifting, the driving issue, this gentleman, if he had been able to get to his car, he would have been gone. An interesting fact was a few years ago, I was teaching a class in Roanoke, Virginia, and one of the officers told me, said a couple weeks before the class, he had noticed a vehicle on the road. It was weaving all over the place, so he pulled it over. There was an elderly gentleman in there driving, started to strike up a conversation. The gentleman knew where he was going, where he was coming from, was clear as day, and nothing appeared to be wrong until the officer looked at the dashboard and saw 2 Post-it notes. The one on the right said said gas, and the one on the left said brake. And he thought, that's a little unusual. So he started to dig a little deeper and found out, okay, well, this gentleman's dealing with dementia. Let me find a caregiver. Without this education, if that officer had not seen, it happened before the class, he was able to pick up on it. But there are officers out there that may not pick up on that and then send that person on their way driving thinking they're fine. Looking at somebody, you can't look at somebody and say, oh, they've got dementia, they've got Alzheimer's. But it's being able to pick up on some of the little cues, some of the little oddities, and recognize, okay, I've got to dig a little deeper and dig a little deeper. But whether it's accidents to driving, and I know it's a difficult thing to get people to stop driving. I'm dealing with that with a family member myself. We're seeing it very frequently, and it's amazing the different ways it shows its head, whether it's the shoplifting, domestics, and things like that. But it's become a huge issue for law enforcement.
Indeed. And I appreciate you bringing up the fact that sometimes, you may stop someone, there may not even be a diagnosis, or they may not be that typical older adult that has dementia. We are seeing many individuals in their 40s and 50s and
Right.
young 60s that look very physically fit, but have young onset Alzheimer's disease and may be showing some of these signs that Dr. Aravich mentioned. We clearly at the association talk about those 10 warning signs, and I appreciate you mentioning all of those. So we talk a lot about accidents and driving, and we know that's an issue with individuals with dementia. Talk just a little bit about indecent exposure. Do you deal with that a lot? Do your officers have a lot of calls?
We've had a few, and I mean, it can be as simple as somebody going to the bathroom and forgetting to pull the zipper up. And they walk out of the bathroom and they're walking around the store, not realizing that they're exposing themselves. And we will have got those calls, and it's a very delicate situation because the officer may get there, and your original report is indecent exposure, but then you find out, okay, well, this gentleman is dealing with a form of dementia. He didn't pull a zipper up. However, you've got mom over there with her 4-year-old daughter who walked by and saw it all. Now, the question is, do you arrest him? Do you charge him? Do you not? Was the letter of the law broken? Yes. Was the spirit of the law, was he intending to do that? Maybe not, but what's going to happen is you're going to get supervisors calling supervisors, getting supervisors. You're going to ultimately get to the Commonwealth attorney, prosecutor, run it by them and say, this is what I have. Is this a case that you want to prosecute? If they say no, I can tell you, when you go tell that mother of that 4-year-old, hey, we've investigated the Commonwealth attorney, or whoever says they're not going to prosecute, that's not going to go over very well. They're expecting something to be done. And the officer needs to do something. He needs to offer the resource. Something has to be done. The incident needs to be documented. Maybe APS needs to be notified just to let them know this gentleman, his family may be in need of services. But I can tell you, you've got a citizen with a 4-year-old daughter who's not going to be happy. And it's a very delicate issue because that mom, you know, thinking my child has to go through therapy for the rest of her life because she was traumatized, you know, you're walking a very fine line, whether to enforce the law, whether not to enforce the law in many of these cases. An example I use, and I actually was teaching a class yesterday. I said, if you take Grandpa, who grew up on the farm, he was on the tractor all day long, riding. If he needed to go to the bathroom, he may step off that tractor and walk right into the wood line, do what he needs to do, hop back on the tractor. I said, how many malls do we have now that have trees and bushes and all this foliage in them where, depending on where he is in his mind, he may all of a sudden just walk into the little wooded area right there in the middle of the mall and use the bathroom. And then you end up with a 911 call where an officer has to respond and try to work through that situation.
Wondered,
Thank you for that scenario.
Sergeant Sutton, if I could just elaborate on challenging behaviors with neurological deficits. They're not unique to the dementias. A whole bunch of different Huntington's disease,
Right.
traumatic brain injury. Let's just work with that one and talk about scenarios there. So I was the former head of the Virginia Brain Injury Council and honored to help lead the first consensus statement for the statewide position paper on what to do with persons who have traumatic brain injury and challenging behaviors. And since I work in the Alzheimer's world, I invited some of the experts in the state on Alzheimer's to join that. Unfortunately, what happened was the brain injury people voted off the Alzheimer's people and dementia people because, don't you know, traumatic brain injury is different than is Alzheimer's disease. That's certainly true on a number of different levels, but as you know, in the Sheriff's Department, more than anyone, they're not different at all when person with challenged behaviors are handcuffed by sheriff and taken away. And so I'll give you the case of Eric Fletcher that we put in that state consensus statement. He was from Virginia Beach and had a challenging behavior issue, tried to kill his wife. She would then eventually get him temporarily detained. He'd come back, try to kill her, eventually temporarily detained. And eventually she came to the realization that he was eventually going to kill her. She had two choices in the land of Thomas Jefferson. One was to take him back and get killed, or two, to abandon him to the state public guardian program, which she did. He's now in a facility in Massachusetts because we have world-renowned experts in traumatic brain injury rehabilitation here in the Commonwealth of Virginia, but Medicaid, in its wisdom here within Virginia, would not pay for the care of those of him here in Virginia. So he had to go to Massachusetts to get probably substandard care, frankly. The whole issue of challenging behaviors with neurological problems is a huge problem that you guys in law enforcement on the front lines face all the time. Somebody is coming at you with a baseball bat. Now, what are you going to do? You know, if it were me, I'm going to defend myself, but we need positive behavioral controls. And I think later on, maybe we'll be talking about formal crisis intervention team training. And the Alzheimer's Disease and Related Disorders Association, notice I didn't call it the Alzheimer's Association because that's not what it's called. It's bigger than Alzheimer's disease. Needs to be pushing caregiver crisis intervention team training as a way to use positive behavioral controls for caregivers not to be in abusive situations. We need lots of people, more first responders who are, for example, emergency medicine docs and those kinds of persons. Crisis intervention team training. I'm trying to push that with the Virginia Medical Reserve Corps, which I'm a non-clinical member. In my opinion, I've stated it to the Corps. I don't believe they are properly trained in crisis management as well as they should be. When they go into a nursing facility and they're volunteering with persons who have advanced dementia, do they really know how to handle them? And my feeling is we need much more training for challenging behaviors, not just by law enforcement, for the whole continuum of care.
Dr. Aravich, quick question for you. Which dementia causes more behaviors than others?
Frontotemporal, I think, is probably the real scary one. Frontotemporal is very much related to chronic traumatic encephalopathy, that you're hearing about with football players and so on. Frankly, there's a debate that is chronic traumatic encephalopathy a separate kind of dementia, or is it a variant of frontal temporal dementia? Now, Ms. Thomas, she's amazing to me. Among the things she's got me involved with, I went to the Washington four-letter word training camp. She got me to do a brain injury thing there at that training camp for the team formerly known by the offensive term. And she also had me on a gig with Jimi Hendrix. Not that Jimi Hendrix, but the global head of research for the Alzheimer's Association. But when it comes to challenging behaviors, frontal temporal is bad because you're going to have more men with frontal temporal than women, and just by sheer bulk, they're really a great risk to one another. So they are good people doing bad things. When a good person does a bad thing, does the person deserve consequences, restraints? Do we deserve to be protected from that person? Yes, yes, yes. But what else does the person need? Ultimately, they need help. They need treatment. And I hearken to Dr. Rowe, who is a partner with Ed Ancella, the head of the Virginia Center on Aging. Dr. Rowe talks about positive behavioral controls in our long-term care facilities and how we need to incorporate many more of those positive behavioral controls by way of crisis intervention team training in our community-based settings as well, to de-escalate rather than have a confrontation with the person who has frontal temporal dementia. Now, let me just add one other thing. The bad news is that some of these brains are pretty hot-wired because of a circuitry in the brain known as the salience network. So it's not too hard to push those buttons. And I'll just give you a picture of part of that. I don't know how well you can see it, but there's a pin right at the tip of my finger pointing to a structure deep inside the brain called the amygdala. It is part of the salience network, but there's a whole bunch of other things. So the bad news is you can easily fire that salience network in persons who have various forms of dementia for negative reasons or positive. So the last time I presented at the Richmond Alzheimer's conference a couple of years ago at the invitation of Ms. Thomas, I talked about the role of music in the brain, and one positive way to fire that salience network is by music. It's amazing how music fires that salience network in a good way. And remember, you know, caregivers are really suffering and they can't communicate with their loved one, but touch, just touching someone. What a powerful thing, the healing power of touch. I'm not talking about any kind of non-evidence-based thing. I'm talking about physically, gently, lovingly holding someone's hand, because they're in there somewhere. So there's many different ways to fire the salience network for good or for bad. Now, what Dr. Ra has pointed out is behavioral mapping. So caregivers, providers of any type should look at the challenging behavior of resident-on-resident abuse. So this guy is hitting people in the facility. Most of the time in the facility, you're going to lock the person up or call the law enforcement. But Dr. Rowe's approach would be to push the behavioral mapping, look at the behaviors that are triggering it. So they find that this guy does it a certain time of the day. After a couple of weeks more, the CNAs and others determine that he does it a certain time of the day in a certain room. And then a couple of weeks later, after they've established that, they go in that room at that time and they figure out what's going on. And they see he sits in the couch opposite the window and the sun is in his eyes. So what kind of sophisticated criminal justice intervention is needed? What kind of sophisticated medical intervention is needed? None of the above. You know what the solution to that challenging behavior was? Pull the blinds. Pull the blinds. Positive behavior controls.
Thank you so much, Dr. Aravich. You are just a wealth of knowledge. I have heard you touch on so many topics of the caregiver stress, the 10 signs of caregiver stress. We could go on about that. And I think we would all agree on this call that more training needs to be done with law enforcement and with caregivers on how to de-escalate. So let's let Sergeant Sutton cover just a couple quick things in his toolkit that he uses to de-escalate a situation if there's something going on, and maybe that can go over to caregivers. And then we want to give Major Dabney some time. Florinda has some great questions for her. So Tim, just a minute or so about some de-escalation tips or communication strategies.
I think the best thing for de-escalation is the knowledge. Officers being trained, people being trained. That's number one. Also, a lot of it is disclosure. Our dispatchers up in the emergency communication system center, they've actually got the computer sitting in front of them. When they get to 911 calls, the address and information pops up. But for the caregivers or the family to be able to disclose that information, that hey, somebody is at this residence, they're dealing with a form of dementia. These are their likes, dislikes. These are the triggers. They may set off that amygdala where, you know, fight, flight, or freeze. They may panic, stress, lash out. But having that information is great, and that's one issue with the tracking systems, the Project Lifesavers and things. It enables officers going to meet the families, meet the individual, and learn about them, medications they may be on. And where this came into play was we had a gentleman in our county who actually fought in World War II. He was in the Navy, and he would walk down the road about once a month. He'd put his Navy uniform on and walk on down the road. And anybody who stopped out with him asked him where he was going, and he would say, "I'm headed to Norfolk. I've got to go overseas." So in his mind, it's 1940s, and we are at war with Japan and Germany. Well, when the calls would come out, I had a couple officers who I would call them and tell them, do not respond down there. One of them actually was of Asian descent. The other one actually had a very thick Russian accent. So had they showed up in uniform, I can only imagine what he may have perceived as a threat to him, because to him, they may have been the enemy. And next thing you know, they may have been on top of him, top of my officer. He may be on top of them trying to hurt them or take their life. And that officer may have to use force. And then that's a tough thing to explain later on, is why your officer, does a sheriff, does a chief, do you train your officers to hurt people dealing with Alzheimer's or any other form of dementia? So when that call would come out, having that knowledge, the family having disclosed the information, we knew about it. I would have particular officers that I would send down there, a couple of whom were in the Navy. So when they responded and approached him, they took on their Navy persona and yelled at him, "Seaman, where are you going? I'm headed to Norfolk, sir. Well, you need to come over here and get in my car." And they would go to a restaurant and sit down and wait until we could get in touch with his son to, reunite them. So the big thing is the education, but having those caregivers give us and disclose the information, whether or not they're in a tracking program, but to have that information, and it not only benefits law enforcement, but fire and EMS. To have that information when they're responding to a medical emergency or a fire, it's imperative to know what's going on, what you're going into, because you may think you're going into a typical situation and it turns into everything else but a typical situation. There are other aspects, the shoplifting. I know that was one. Walking after the loss prevention officer has tackled, grandma in the parking lot and drug her back to the loss prevention officer. The officer gets there, and first of all, that individual with dementia many times won't even remember having done anything. And what better victim than somebody who can't remember? So you get back there and come to find out through your investigating that the officers are supposed to be doing, asking questions, learning. You find out that her grandson gave her that bracelet for her birthday last year. She happened to be in a store and saw the exact same bracelet, thinking it was probably hers, took it and put it on and walked out of the store. So it's a very logical explanation, but it's understanding how the dementias and different disabilities, illnesses, and brain injuries work to be able to work through the problem. It's not always what you think it is when you get there.
Right.
I wonder, Sergeant, if you could comment on some of my heroes, Adult Protective Service. They're largely social workers. They are basically the boots on the ground when it comes to healthcare. I asked during a training session in Southwest Virginia, one of the leaders out there, how come you do this? He said, once in a while we save somebody. Pretty tough job. Comment on APS as it interfaces with law enforcement.
Well, as law enforcement and public safety, we're mandatory reporters. If we run into a situation or find somebody who may be in need of services, legally, we are supposed to document that situation. We're supposed to notify APS, give them the information so they know. And then they can dig in a little deeper and find out if this family is in need of service and offer them services. One thing we get in our job constantly is check the welfare. We've got the son in one state wants to check on his dad. Dad will not answer the phone. We go over there, knock on the door, make sure dad's okay. And many times they'll come to the door and say, oh yeah, I'm fine. Well, can you call your son? I try to stress to officers, be inquisitive, you know, have that conversation. You're more than a uniform, you're a person. Ask him, say, hey, can I come in and sit down and talk to you for a minute? And if you go in and you see in that house that there's one little pathway to get through the house, maybe to the kitchen, and everywhere else is piled up newspapers and mail. And I said, try to get to the refrigerator if at all possible, because many times that food is 3-4 months old, and that is what they're eating. Now, the reason that mail and papers and everything are stacked up is because many times that hoarding takes over. They cannot discern what to get rid of and what to keep, so they're hanging on to everything. But what I don't want, you know, and if you see that, contact APS, let them know. They could be the miracle worker that comes in and helps that individual and or the family. What I don't want to happen is you go make contact with dad, look at him through the window, say, hey, call your son. He's trying to get in touch with you, and you leave. And then a week later, somebody calls and says, you know, the mail is just piling up in that mailbox, and there's a really terrible smell coming from that house next door. I said, it's not necessarily that you did something wrong, but I would not want to be that officer when they come and say, you know, we found him deceased in the house and looks like he's been there for a week. Weren't you out there last week? And you're explaining, yeah, I was, but I didn't, you know, I just looked at it. I would not want to be that officer. So APS is a huge resource. And I think what scares many caregivers is the general public looks at law enforcement many times and says, well, if I call them, if they show up, they usually leave with somebody. So they're hesitant to call us. Or they're going to show up and they're going to call APS, and I'm going to be told I'm a terrible caregiver because dad wandered off. I let dad wander off. So we in law enforcement, we need to break that wall down. And like I said, I'm out here to serve and protect all, you know, and many times when those caregivers do call us, they've done everything they can not to call us. And when we do respond, it's a crisis situation. They finally got to the point where they did not know what to do, and it is a crisis. So, Doctor, you talk about crisis intervention training. Our agency, all of our officers are trained. It's necessary, whether it's mental health issues, it's Alzheimer's, a form of dementia, children with intellectual disabilities. That training needs to be done so we can get in there and offer their assistance. Our job, we become social workers. APS, yeah, social work, law enforcement, it's not just going out there arresting bad guys and enforcing traffic. You know, we're getting called because citizens upset because the neighbor's cutting the grass and shooting the grass on their yard. And then we get called and we say, well, have you mentioned anything to them about it? Well, no, that's your job. And we've actually had an individual go to Walmart, buy a pair of wiper blades, not know how to put them on a car, calls 911, wants an officer to show up to put the wiper blades on. So, and we have to go. You know, why do people call 911? Because we show up. That is the simple reason.
Thank you for doing that, Sergeant Sutton.
Yes.
I wanted to give Florinda some time to chat with Major Dabney about some great programs, just very similar to what you're talking about.
Yes.
Florinda?
Thank you so much. Thank you so much, Major Sutton. Sergeant Sutton, for addressing those important issues that individuals living with dementia face, such as those auto accidents and driving issues, the indecent exposure, the guns in the home, you know, the elder abuse. These are important topics, and they appear to overlap with behaviors that our sheriff's department face. So, Major Dabney, not only are there concerns about individuals with dementia that are driving, you know, the things we just talked about, but wandering is one of the biggest concerns for caregivers. In fact, just about 2 days ago on the news, there was a news flash with a woman in the area that had gone missing, and they said that she had dementia. So what happens when a person goes missing?
Okay, so regarding Richmond's Project Lifesaver program, when we orientate our caregivers, we instruct them to call 911 first. Reason being, part of the enrollment process is to create a participant profile. We send that profile to Department of Emergency Communications. So when DEC receives that call from a caregiver saying, hey, my mom is no longer here. She has dementia or she has cognitive issues. We need help. Police officers have immediate access to that person's profile. The profile, of course, contains a picture, very important information such as age, height, weight. We also have notes as far as areas that person likes to frequent. The second call is made to Richmond City Sheriff's Office, at which time our response or our search team is activated. We have a core team, I would say about 10 deputies, and we dispatch throughout the city with our information, with our profile, to conduct a search for the person who has wandered away from a safe place. After that, and now I will say we partner closely with, of course, Richmond Police Department and Richmond Fire Department. Richmond Fire Department has the equipment, the search equipment, to come out with us to help locate someone who has wandered away. Richmond Police Department, they don't have the technology, but they, of course, have patrols already out in communities, and they are very, very, very helpful when it comes to us conducting a search and helping our response team. I am happy to say we have 100% success rate. We've had several call outs this year. We have a wonderful lady, she's in her 80s. She's from Haiti. And what we've noticed a pattern with her is when the seasons change, when it gets cold, she often leaves home to go back to Haiti where it's warm. So we have learned now her route, if you will, as far as when she's walking back to Haiti. And again, Richmond Police Department, I can't say enough, they've been very instrumental with helping us with our call outs. So pretty much that's what happens.
So with that being said, can you help us? What kind of community resources are available to families in these difficult situations? I heard you mention, yeah, a few.
Yeah, absolutely. Now, we work closely with Senior Connections. They are great. They have so many different activities, so many different places adult seniors can go for, it may be a day center, to give a caregiver a break, okay, from taking care of someone with dementia or Alzheimer's. We work closely with, of course, Richmond Department of Social Services. We work closely with Adult Protective Services. They have been wonderful. We had a recent case where we went to visit one of our seniors. She was not home. This went on for about 48 hours. We reached out to Adult Protective Services. They conducted a welfare check, and we learned that her family had actually relocated our participant to Philadelphia, Pennsylvania. And we have received pictures, and all is well. So we can't say enough about those good people. We work with, of course, Human Services, Richmond Office on Aging and Disabilities, RVHA, and the Richmond area is full of adult centers that are very good with providing a safe place for seniors to socialize, to play, have a good time, and get back home safely. And pretty much that's the list of resources we have. And we use.
Thank you so much. That was a wealth of knowledge. Thank you for putting that out there. You already discussed that, the Are You Okay and Project Lifesaver. So there is many things available, and I appreciate that. Dr.
Board
Aravich,
member.
were you trying to say something?
Yes, thanks. I just wanted to say Project ECHO of the Alzheimer's Association, for those that are involved in long-term care, is a really fabulous resource as well. But as far as community-based resources specifically are concerned, one major gap in medical education is that too many clinicians think once they give the diagnosis, the problem is over for the person and the person's loved one, and just come back again for some symptomatic treatment in a few months. And so we need to provide much more education for our medical students, our physician assistants, and others about community integration by way of a continuum of care. And may I say, Eastern Virginia Medical School has been recognized 7 times in the last 20 years as one of the top 3 medical schools in the United States for outstanding community service, more than Harvard and some of the other fancy schools in Virginia are concerned. And so part of our job we take seriously is what are the community-based resources clinicians need to be connected to and be aware of. And I told the social worker conference here in Virginia a few years ago, most MDs would not know a social worker if they fell over. I think that's pretty sad.
Right. Can I add something to that? The wandering issue. Can I add something to the wandering issue?
Sure.
Yes, Sergeant Sutton, and then we'll open it up to questions. We want to give everybody on the call time enough to ask theirs. So yes.
I think one of the issues, as far as boots on the ground, can you hear me okay? There we go. Is officers building the partnerships between public safety and these caregivers and individuals. The thing is, many of the caregivers that I've run across, they're so hesitant to call 911 when that individual wanders off. And they will go out searching for hours and hours, and we're losing valuable time. Average person can walk 4 miles an hour. So you're talking a huge area exponentially every hour. But it's stressing to those caregivers that when they do wander off, it is an emergency. We need to get there as quickly as possible. And there's studies out there that show 33% of these individuals, if they're not located in 24 hours, they will not be found alive. And the reason being, many times they're not dressed for the elements. If it's 100 degrees outside, they will have a big wool coat on, stocking hat. 10 degrees outside, they're gonna many times not have shoes on, have the night clothes on, and they're gonna take off. And of, about 60% of them will wander off. So the caregivers need to be made aware of that and know that, no, they're not bothering us. We're partnering with them to try to help take care of their loved one. So when they turn around, they're gone, call 911. If they find them in the meantime while we're on the way, we're already out there. We can turn around and head somewhere else to take care of another problem, but they need to know that that's imperative that they call us immediately.
Absolutely. Thank you so much for that, Sergeant Sutton.
We're
going to move into the...
What Officer Sutton is saying, the same thing happens in the correctional setting. We see individuals who will, during their downtime or the time they're not supposed to move, they will start to wander, and we've had to re-educate officers. Please call us in medical. We'll let you know, is this a behavior of dementia? We had a recent situation where someone with dementia started wandering during an off time, and officers responded, and they knew to call us this time. And the first thing I said was, please be advised, this individual has dementia, and they handled it very differently than they would any other individual.
Right. Thank you both for that bit of information. So this part of our program, we're going to go into the question and answer portion. And my esteemed colleagues, Lori and Jessica, will take some questions at this time.
Okay, this is Lori. There's a question in the chat here related to driving. So I'll just throw it out to whoever would like to respond. If a person is still driving well, but has an accident, are their caregivers charged with a crime for letting them drive? Is the driver prosecuted more harshly?
I can answer that. I've never seen a case where the caregiver is actually charged for that, because I tell you, driving is one of the most difficult things to get the individuals to stop doing. There is a DMV medical review form that we can fill out along with them being charged for the accident, and we kind of let the judge figure it out. But DMV during that time can call them in and have them retested to see if there's an issue where they should not be driving. But one of the issues is I try to make the caregiver not be the bad guy, if at all possible. If one of my officers or me have to be the bad guy, you know, that person dealing with dementia may forget everything else, but they're going to remember their son or daughter took their license, won't let them drive. And I don't want to I try not to put that burden on that family member because they're dealing with it daily. Let me be the bad guy, or let the courts or let DMV be the bad guy. But, you know, as far as the driving and trying to get them to stop, I know it is difficult, and there are many different ways that you can disable the vehicles. And I tell officers that if you think about it, those keys, having those keys in your hand, they are your last freedom as an adult. That set of keys. It's a tangible object. If you have to give them a set of keys that look the same but do not go to anything, give them a set of keys that do not go to anything and let them carry them, and they may think they can drive. If they try, it won't work. But the biggest thing I've seen, and I've also heard a lot of times at DMV, they will send the individual back to the doctor, and like Dr. Aravich was saying, you know, some doctors wouldn't have a clue. They say, oh no, they're fine. They're fine to drive. They're fine. Or they diagnose them with something and send them on their way. But nobody's following up with the family about having to deal with some of those daily issues. And I find it ironic that somebody with a gun and badge sits down at the kitchen table and explains to the caregiver, this is what you're going through, and this is why they're doing this, and this is why they think you're not their child or their spouse or whoever. But the driving thing, I would encourage, if there's an accident involved, let the officer know. If you've got to go to court, let the judge hear the information. You've been trying to get them to stop driving. They will not stop driving. Maybe the judge can do something to make that happen. But I've never heard a case of the caregiver being charged.
Mm-hmm. Lori, if I could respond to that as well. So there have been several cases where litigation has been brought against the primary caregiver of someone who has a diagnosis of Alzheimer's disease or dementia. If they, during the discovery process, if it is determined that the primary caregiver was aware that the person had a diagnosis and they continue to allow this person to drive because people, they take chances. There have been several successful cases where litigation was brought against the caregiver.
Awesome.
So it's important to share that information with families, because they will say, you know, we're the only ones on this road. There's nobody else here. He just goes to the mailbox and then he comes back. You really can't take chances with driving.
Yeah, I can see a lawsuit, something like that coming. But as far as the officers on the scene, I've never witnessed or been exposed to the actual charging the caregiver. But I can see where Ms. Thomas, what she's talking about.
Let me just say, given the importance of driving, particularly when we have substandard public transportation, not a political comment, but an evidence-based comment, I think. When you take, as you said, Sergeant Sutton, the driving away from an individual, it can be catastrophic. But on the other hand, you got to protect the public and themselves. That's where an objective assessment of driving competency by driving simulators is so important. Our geriatrics program was one of the leaders in doing that. And you got to explain to the caregiver, it's not my opinion. Here, let me show you the results. But you got to also understand caregivers are people just like the rest of us. And particularly now with COVID going on, the rates of anxiety disorders and depression have doubled and tripled according to the CDC. So the caregiver has his or her own alligators attacking their boat. At the same time, they want to do right by their spouse. A driving simulator at least gives objective data to try to mitigate this tension that you speak of, Sergeant Sutton.
And Annette, just one last point, you know, because driving is a point of contention for so many families. As on the putting a social worker hat on, when you're working with these families, one approach would be, as opposed to going in and taking something away, consider taking something, but also bringing something to the table. So if you're going to have this conversation about driving and how it may not be safe, we may need to take the keys away, but still offer a space for independence for the person. Like, we can help set up Uber, or we can help set up Lyft, or we've got this neighbor or family members or church members that will pitch in, because what the person hears is to Sergeant Sutton's point, you're taking my independence. So if you're going to have that conversation about driving, come to the table with options to help maintain that sense of independence, and that may be helpful.
Thank you, Tina. I would agree with that. Lori, Jessica, I know that there was some questions about COVID.
Yeah, hi, this is Jessica. I have another law enforcement question. Is there a way to register your home to allow your local 911 to know that you have a household member with a dementia or another cognitive impairment?
I would call most agencies I've dealt with across the country have a CAD system where you can put all kinds of information in. You pull up the address and just fill it. I actually did one a couple months ago for a lady in the county who has a daughter who's living on her own. She's got Down syndrome, living in an apartment complex, and they were practicing. She was living with another girl with Downs, but they were practicing fire drills. And they discovered that once the fire alarm went off, she went and hid in the closet because she was scared. Now, I said, that's information that fire and EMS needs to know should they respond there for a fire. So we typed everything up, gave it to the dispatchers. They put all the information in, linked it to that address so that they are forewarned on the way. What I would do is contact your law enforcement agency, whatever jurisdiction, whatever agency that is, ask them who to speak to. They will probably give you a form, or they may take the information over the phone. I would want to know all the ins and outs, the triggers, what to do to help calm them down, what not to do, what not to say that may set them off. But any information that would improve the encounter or the interaction and make it go smoother and safer, I would share that information, disclose it to them. And yes, they can link that to phone numbers, addresses, whatever you need. Every agency I'm aware of does that.
And not least of which is the Alzheimer's Association as well. What a wealth of information the regional chapters are. One of the major barriers we have with our medical students in training is we teach them early on, after the diagnosis is made, refer the family to the resources of the Alzheimer's Association. They remember that when we test them in the first year, but when they're out in clinical practice, I'm sorry to say they kind of forget that the Alzheimer's Association should be one of the first points of contact. It should not be law enforcement sitting around the kitchen table saying, by the way, it should be the associations, the advocacy groups that are out there. Too many of our clinicians don't know that. They just have the medical model, and they're not trained effectively in community-based continuity of care issues.
Yes. All right. Lori, Jessica, other questions?
I'll go ahead. This is Lori again. This is a question for Major Dabney. And the question is, has there been an increase of wandering incidents since COVID-19?
No, ma'am, we haven't really seen an increase. We had a call out a couple weeks ago, but no, ma'am, we have not received an increase in the Richmond area.
Well, may I comment on COVID, not just in the context of the legal system, but in general? If associated with COVID are these increased rates of suicidality and depression and anxiety that the CDC published on just a few weeks ago, that means persons who are working in our with incarcerated individuals, persons who are private family caregivers, persons who are professional caregivers are in a position to do things that maybe should not otherwise be done. And so, at least as far as I'm concerned with long-term care staff, I think that a mental wellness checkup is as important as a physical wellness checkup as they're going to work, because the certified nurse assistant who's working 2, 3, 4 jobs, not paid very well, who now has exaggerated psychiatric problems, is potentially not going to do right by the resident and potentially not going to do right by herself, since many of them are men. You know, we have this physical focus on COVID. I do not believe the behavioral complications of COVID are receiving the public health attention that they deserve as related to persons with special needs and otherwise.
Okay. Thank you. Lori, Jessica, we've got time for a few more questions. We'll try to wrap up the Q&A in just about 10 minutes, and then we'll finish up with the rest of our program. We clearly know that we have a lot a lot of conversation that can happen around this topic, and we clearly know we've got a lot more work that we need to do on it. So.
Hi, this is Jessica. Got a question about the role that behavioral health and the behavioral health departments across the state, what role they play with somebody with dementia, whether it is working in conjunction with law enforcement, or do I say opposition? How do all those pieces come together if someone is in need of mental health services, but 911 gets the call?
In my environment, I see psychology quite often when we have individuals who've been identified as who are having dementia issues, and they assist us quite often with helping us track the behavior. This way, we know when, for example, adjustments to medication need to be made, or there's an escalation of their behavior. So psychology in my environment has played a major role.
My comment would be the only problem with our behavioral health providers is there are not enough of them. And when it comes to interfacing as a system of care, I would argue there's no better example of a failed system of care than it is the integration with behavioral health in general, whether it be dementia or depression or schizophrenia. So we need to improve much more substantially our appreciation for and our funding of persons who are providers psychologically and psychiatrically. This brings me to Medicaid reform and CCC plus, Commonwealth Continuity of Care plus. The CCC plus program is an integrated behavioral physical health program with evidence-based medicine behind it is pretty impressive. And so persons who are on Medicaid or dual eligible on both Medicare and Medicaid can be eligible for this integrated behavioral physical health system, which is designed to keep people out of jails, keep them living independently. Do you know how many of my clinician friends know about CCC plus? Hardly any. Hardly any know about that. They know about cholinesterase inhibitors, but do they know about how to get health insurance and an integrated behavioral physical health program going? The Substance Abuse Mental Health Services Administration, SAMHSA, has been begging American medicine for years to integrate behavioral with physical health. And I'm sorry to say it's not very well integrated at all. We need to do much better.
Jessica, Lori, any others?
I see one more here, and it talks a little bit about someone out in the community, a citizen in the community actually being the first person to come upon somebody out in the community with a dementia-related issue. They appear to be in stress, they appear lost and confused, and this is specifically for Sergeant Sutton. What would you suggest, or how would you advise citizens to the best way to respond to that person and help them?
I would say immediately call 911, get an officer there. Hopefully that officer's been trained. I would hope they have been. But we have this happening constantly. We had it happen 3 weeks ago. We've got an auto shop in our county where they called in and said, there's an elderly gentleman here, he pulled up and just came in and started talking to us. It's something, they couldn't put their finger on it, but just something did not seem right. And when I heard the call come out, I kind of assumed, okay, this is what we're dealing with. We're dealing with dementia. A couple other officers headed up there. We got there and I started talking to the gentleman and I came to find out years ago he'd been a police officer in another state, but he had no idea where he was. He had driven about 2 hours away from home and he thought he was coming to get the car worked on. Once he saw the name on the side of the building, the place where he gets his vehicle worked on in Northern Virginia is got the same name. So he figured he was where he was supposed to be. But he'd been driving all the way from Northern Virginia all around the state and ended up here. But I would say if they pick up on something that is not quite right, try to stall the person. I mean, don't grab hold of them and hang on to them, but do what you can to stall them, occupy them, preoccupy them. Call 911, get an officer there, and then we can interview them, talk to them. If nothing's going on, nothing's going on. But I would hate to think that person is just sent on their way because they're going to drive and there's no telling where they would end up. But I'd say try to get your public safety there. Hopefully the officer is going to call fire and EMS, and maybe it's a medical situation that's occurring right then that they may need treatment. But once that citizen picks up on something that's just not right, I'd say call 911 and get one of the officers there.
May I just echo and reinforce what you said, Sergeant Sutton, and recognize, of course, that there are lots of people with all kinds of different pathologies that are in that similar kind of situation. And on the street, you don't know if it's dementia or schizophrenia or traumatic brain injury or whatever it is. But the remarkable thing about these pathologies that I find troubling and I find really humanizing is that radar in their salience network is jacked up. And so they can take and perceive threats just by the way you stand, just by way of the tone of your voice, just by way if you approach them aggressively or not. So you don't want to touch them and you want to watch your nonverbal language very much. But the other thing I find humanizing about this ability, the salience network radar being turned on, they know if you're for real, they know ultimately if you have good intentions, depending upon the severity of impairment. And frankly, I'd much rather work with persons with severe cognitive impairment who are humble and have great integrity rather than generals and fancy academic types. They remind me what it is to be human. I'll give you an example. Westminster Canterbury and Chesapeake, one of the best long-term care, continuing care facilities you're going to ever see, a 5-star rated facility. We're doing some research there, and there was a person with advanced dementia in a wheelchair, pretty much knocked out. Well, I was collecting saliva samples from her, and her radar was turned off until a guy came walking past her playing Johnny Cash on a guitar. Now, I don't wish to offend people from Virginia, but I hate country western music. That's not my thing. But she was, to quote the movie, alive inside, and I would encourage everyone to see Alive Inside. She was awakened by what was a positive find her salience network. She started dancing. Her and I were dancing in her wheelchair. She told me she was a teacher, how many of her students were journalists and wrote books and stuff. So that salience network, you got to be careful how you fire it when you approach somebody on the street, when you don't know what's going on. Call 911. Be very, very careful in what you're doing. But also, you can sometimes take advantage of it once you figure out who the person is, particularly as a caregiver, you know, sing together, dance together, all of those kinds of things.
Yeah, like the doctor said, when I get there, you know, you can't tell here, but, you know, obviously with that uniform comes an ego and some a little too big of an ego, but that the uniform itself is intimidating to a lot of people. And me, myself, I'm 6'4", I'm 270 pounds. So for me to walk up in a uniform with that hat on and try to, you know, for many people, it would be intimidating. Now, I'm not telling officers to jeopardize your officer safety. You need to be ready for anything and everything. But, you know, I went up to this gentleman who was lost. He obviously was a little confused. We sat down on a park bench. I sat on one side, so my weapon was not on his side. I was aware of my surroundings, but we sat on that park bench and we sat there and talked about his short career in law enforcement. And he had told me about how his wife had passed away. And we sat there for an hour and a half, 2 hours, waiting for his son and daughter-in-law to come down from Northern Virginia to get him. And this is what it was amazing. I went up to the son and I said, "I'm sorry to hear about your mom passing away." And the son said, my mom's not dead. And I was like, "Really?" He said, "No, she's alive. She's got Alzheimer's." The two of them live together. And so none of the story matched up, but there's no need for me to come in. I have to realize that uniform it's a wall for a lot of people, and it's very intimidating. So when we go in as officers, we need to tread lightly, just like the doctor said. You know, there's nothing wrong with sitting there talking, singing a song with them. I've sang little rhymes. I've gone to some of the adult daycares and visited people and sit there and sang songs with them. I know it looks a little odd with an officer in there singing songs, but sometimes you do what you need to do to take care of the citizens that you're sworn to protect.
May I just add, I'm not an Oprah Winfrey devotee, but she's got this whole thing going on. Just say hello. Just say hello. The National Council for Behavioral Health recently had a webinar where stress the need for just reaching out and in a kind way saying hello to someone. I can teach my medical students to do brain surgery in a much easier way than it is to teach them to be nice.
Absolutely. Well, thank you. Thank you all for the great information that you've provided today. And again, we knew this topic would be so very important, and we may need to do a follow-up to this topic because clearly we all have passion. We have so much more to say about it, but I wanted to give you an opportunity to hear from a couple of our staff members about some exciting things that the Alzheimer's Association is doing. And so Emily and Katie, take it away.
Thanks, Annette. Can you hear me? This is Emily.
Yes.
Thank you so much for giving me the opportunity. I have enjoyed this conversation so much, and I am learning so much today. My name is Emily, and I'm the longest stay manager for the Central Western Virginia chapter, as well as the Southeast Virginia chapter. The longest stay is a signature fundraising experience of the Alzheimer's Association, and it is a year-round effort that culminates on the summer solstice. And I call it an experience because it truly is. It's not just a one-day, one-time event. It's very flexible and very creative. We say the day with the most light is the day we fight because our goal is outshining the darkness of Alzheimer's disease. Participants can choose any type of fun activity that they love and mold it into a fundraiser in honor of those that they love who have been affected by Alzheimer's. We've seen trivia nights this year, bike rides, baking classes, painting, cornhole. The list goes on and on for all of the fun things participants have been able to do. And I'm here to help them find a way to turn passion into purpose. And I can definitely put my information in the chat. We're really excited because next week registration opens for the longest day on September 2nd, and that'll be for our 2021 season. We're actively looking for volunteers as well as fundraising leaders. So if you have any questions at all, please reach out. Thank you, Annette.
Oh, thank you, Emily. And, you know, these events are so important because all of the great programming that we do, all of the great research, the advocacy, all of that could not happen without events such as the longest day and the walk. So Katie, tell us about that.
Thank you all for having me. I learned some knowledgeable information today as well. So I'm Katie Hood. I'm the Director of Development with the Richmond chapter, and we are moving forward with the Walk to End Alzheimer's. The world may look a little different right now, but one thing that has not changed is our commitment to ending Alzheimer's. And this year, the walk is everywhere. We're telling everybody the walk is on every sidewalk, every trail, every community, every park that you can visit. And so while health and safety are our top priorities for our constituents, we won't be hosting the walks this year in large groups, in-person gatherings. Instead, we're inviting all of our teams and families to gather in smaller groups of friends and families and walk in your own community. So we are still walking, we are still fundraising, we are still bringing awareness to this disease so that one day there is a world without Alzheimer's and all other dementias. Most of our 99% of all of our programs, our services, our education are offered at no cost, and that's through fundraising efforts like the Walk and the Longest Day. The walk is held in over 600 communities, so you can visit ALZ/walk and you can find the walk that's closest to you. But like I said, walk is everywhere this year, and more than ever, I think in this year, we need people walking because Alzheimer's didn't stop when COVID stopped all of us. So we are on a big mission this year to bring big awareness and big funds to ending this disease. Thank you guys so much for having me.
Oh, thank you, Katie. Thank you, Emily, for joining us. We appreciate it. So I would like to just kind of start the wrap up with a resources update, just to kind of give you an idea about some of the things. And Dr. Aravich, you've talked about so many of our programs that we do, the educational programs, communities, and in communities, all are being done virtually and online right now. But just an example of some of the topics that we cover are 10 signs and communications and behaviors, just information that people can put in their toolkit to make the lives of older adults living with dementia better, or the caregivers stress, all of those topics. We also do a lot with support groups. We have support groups of all types, individuals living with dementia, their care partners, millennials. We have early stage programming. We have care consultations that can provide one-on-one or family support. We also do a lot around advocacy efforts and trial match, and that's just a few of our programs. But the one that I really wanted to highlight today was the 24/7 helpline. 24/7, 365 days out of the year. Anyone on this call, anyone, anywhere can call and talk with a helpline specialist who's a master's levels clinician that can listen to a person's concern, problem solve with them, or sometimes just be that listening ear that that caregiver needs at that point. There's bilingual staff, and so we're available 24/7, 1-800-272-3900. Okay. And then I would like to say thank you to all of our panelists, to all of the attendees today. I would like to say specifically, thank you for being here. On the slide today, you'll see the upcoming events. If you'd like to check any of those out, you can register at 1-800-272-3900. We do have an annual conference coming up, and you'll see the dates on the screen there. September, for those of you calling, September 15th is our kickoff for that. Okay. And then I would like to say thank you, especially to the folks that I had questions for. Sergeant Sutton, thank you so much for your information, for your commitment. I'd also like to say thank you, Dr. Young, for everything that you're doing to make the lives of individuals better. Florinda?
And, thank you so much, Dr. Aravich, for your great perspective, and Major Dabney, really appreciate you taking that time out from the Sheriff's Department to bring us that information. Yes, thank you so much.
Okay, so I know that we have just a couple minutes left on our time together. And Florinda, okay. We have a couple minutes, so I wanted to give each panelist just 1 minute to do a wrap up. If you had one last thing that you would like to tell the collective group about something that you feel like is maybe a thing that could change this world and make things better, what would it be? We'll start with Sergeant Sutton.
I think just understanding what the caregivers and what the individuals with Alzheimer's and other dementias are dealing with. When I do my classes, I tell everybody, I don't care who you are, but at some time in your life, you're going to either be professionally or personally affected by some of this. And to have that understanding, you know, and show empathy when you're interacting with the families. You know, I always talk about our uniform. When I joke around to people when I get ready for work, I say, I got to go put my costume on. And they're like, costume? I thought it was a uniform. And I said, no, I said, people see our uniform and they expect a certain level of service, professionalism. And you could be the biggest introvert in the world and put that uniform on, and you're playing a role. You better get out there and you better interact with the public, and you better, you know, how else are you going to get information from people other than having that personal contact, that interaction? And I said, you get out there and, you know, I don't care who the person is. My job, we see the richest of the rich, we see the poorest of the poor. And it doesn't take but a snap of a finger for you to be down on your luck with no house, no car, walking down the road. I said, so you treat every single person you deal with out there with respect. Those caregivers sometimes suffer more than the person with the Alzheimer's dementia, okay? Because they're losing that person. That person is disappearing. And go out there, show them the respect, show them that you care and you want to do, and I want you to do everything in your, that you can, that's possible to help take care of them. We can't solve it all. And I can go out there and train everybody and train caregivers. We can't solve the problem, but it's a problem there and it's not going away. Law enforcement, we're going to be dealing with it. We will be dealing with it. So why not understand what you're going to be dealing with and have those tools on your belt to be able to deal with it? And I would just stress that to every person, every officer, public safety officer, and like I said before, general public, anybody that comes in contact with the general public needs to understand. I want to thank you all for the opportunity to be here.
Thank you.
Sergeant Sutton.
You're truly a hero. Dr. Young, and then I'll throw it to Florinda for her.
Well, I want to
Do
thank
you
you
have
all.
any?
Yes, well, thank you very much for inviting me to this wonderful discussion. If I could say one thing, I would say to anyone who has contact with the public, anyone who's in, whether it's in a correctional environment or whether it's the public, remember, these are people's wives, husbands, sons, fathers. Everyone needs to be treated with respect. When I speak to the officers here, I really emphasize that. When you have someone with dementia who's in a correctional environment, remember, they are somewhere else. They're not here. And if you can remember that and treat them with the utmost respect, how you would treat your mother if this was your mother, or your father, or your brother, then I think that we as correctional officers could make this a better place. We know that these individuals may have committed a crime. However, they're still human, and we need to respect that.
Yes, thank you so much, Dr. Young. Dr. Aravich, I know you have so much. What's that last one comment that you have? You're on mute. Uh-huh.
Ms. Florinda, you gave me an inch. I'm going to take 3 inches if I'd be so bold. One, don't forget the Alzheimer's disease and related disorders minority outreach programs and packaging that is out there to help increase better outcomes. I would quote the diving bell and the butterfly, where this guy is locked in his body because of a stroke. Always hold fast to the human inside of you, as well as the human inside of the person with dementia. And then I would quote George Bernard Shaw, because this is, I think, emblematic of social change agents and leaders for the greater good of the community that is embodied by those of you from the chapters who've organized that. Shaw says, some people see things as they are and ask why, others see things that never were and ask why not. So be dreamers, be dreamers.
Thank you so much for that perspective. Always such good information. Major Dabney, you're last. Can you just wrap it up and give us that one thing that you would say?
Yes, I would say when it comes to our senior citizens and individuals living with dementia, we know these folks they're just absolutely precious, and they're very vulnerable. And I would say just an act of kindness to an individual or individual's family, because it's very difficult for caregivers to live and love a family member with dementia. And know that most jurisdictions in the state of Virginia have excellent programs such as Project Lifesaver. They are full of professionals and resources. And I would ask that you make contact with these folks. And in turn, that would just help protect some of the most vulnerable people in our community.
Thank you so
What
much.
a beautiful way to wrap that up. What a lovely, lovely way. I hope that I've been trying to watch some of the comments in the bottom. It sounds like everyone has been impressed with the program today. And you may very well see that we do need to do a follow-up conversation to this, because there was a lot to unpack on that. So without further ado, I will go ahead and say thank you, thank you, thank you to everyone. Be safe, be kind to everyone. And each of you are a hero in my eyes.
Thank you.
Thank you.